join us there in person if you can. And it's my real pleasure to introduce our esteemed speakers for today, Dr. Ho and Dr. Kosyakovsky. Dr. Ho is the Harrison Family Endowed Chair in Cardiovascular Research, the Director of Research for the Division of Cardiovascular Medicine at Beth Israel Deaconess Medical Center, and the PI of the Cardiology T32 training program. Dr. Ho's research focuses on clinical and translational patient-oriented investigation to elucidate mechanisms driving cardiac remodeling and heart failure and obesity-related cardiometabolic disease. And she's discovered novel mechanisms and mediators of HFpEF and demonstrated the importance of exercise publication in HFpEF diagnosis. She's a committed mentor to residents, fellows, and faculty, and has won numerous mentorship awards. And the great Leah Kosyakovsky is a recent graduate from the BIDMC Cardiology Fellowship, a T32 fellow with Dr. Ho's research group and a former chief cardiology fellow. In addition to her research successes, she has received numerous teaching and clinical excellence awards, and she volunteers her time mentoring high school students interested in science. And we especially appreciate her taking the time to join us, as she's a busy advanced heart failure and transplant cardiology fellow this year. So Drs. Ho and Kosyakovsky, thank you so much. And I'll turn it over to you. And I think I butchered your name, Leah. I'm proud.
No, you did great. Jen, I'll share the screen. Let me know if it's sharing okay, and then I can go ahead and start.
Looks great.
All right. Well, hello, everyone. Welcome. So today, Jen and I are going to be presenting our grand rounds titled, Is HFpEF All Obesity-Driven? The Evolving Heart Failure Landscape. And these are our disclosures. So I'm going to start out with a patient case, and then I want you to keep this case as well as the questions I have in mind as we go through the rest of the talk. So first, we have a 57-year-old woman who presents to clinic with a 6-month history of dyspnea on exertion and intermittent leg swelling. She has a history of prediabetes and an elevated BMI. And recent PFTs and arresting TTE have been unrevealing, and her NT-proBNP is at 120. So the questions I have for you all are, 1, does she have HFpEF? 2, what diagnostic testing, if any, would you pursue? And 3, what treatments would you consider? So we're currently facing twin epidemics of both obesity and HFpEF. And here are pictured CDC data on the age-adjusted trends in obesity amongst US adults. And you can see from the 1960s up until the mid-2010s, we have a significant increase in the prevalence of both obesity and severe obesity, to the point where now more than 40% of US adults have obesity and another 30% are also overweight. Similarly, we've also seen a parallel rise in HFpEF prevalence as well. So this graph shows over a similar time interval the increase in heart failure admissions for blue, preserved ejection fraction, and purple, reduced ejection fraction heart failure. And over this time, the prevalence of HFpEF has been rising steadily, overtaking HFrEF as the most common form of heart failure. Now, we feel that obesity is one of the major drivers of HFpEF, and actually more than 80% of patients with HFpEF are either overweight or have obesity, which invokes several interesting questions. 1, what is the burden of HFpEF among individuals with obesity? 2, how does obesity drive the pathogenesis of HFpEF? And 3, is obesity really the whole story of how HFpEF develops? So these are the 3 questions that we're going to cover over the course of the talk. So to address the first question of the burden of HFpEF and obesity, we have to address the challenges of diagnosing HFpEF in general. Now, HFpEF diagnosis is not straightforward, and it's certainly less straightforward than it is to diagnose HFrEF. HFpEF diagnosis hinges on the presence of biomarker elevation, including NT-proBNP, as well as subtle manifestations of diastolic dysfunction on echo, neither of which, unfortunately, are reliably present. You can see here I've highlighted 2 heart failure scores for HFpEF. On the left is the HFpEF score, and on the right is the H2FpEF score. And as you can see, both of them rely pretty heavily on clinical features as well as these features on echo and biomarkers. But the assessing the burden of disease is complicated by the challenges of interpreting these findings, particularly in the setting of obesity, which, as we mentioned, complicates about 80% of these cases overall. So there are many limitations of echo and HFpEF in general, and actually we learned from Paragon Heart Failure that 32% of people with HFpEF actually have no echo abnormalities whatsoever. And in obesity, this is further challenged by the fact that measures of diastolic dysfunction, such as the mitral EDE prime, may actually underestimate LV filling pressures in obesity, which we hypothesize is due to greater external restraint So if you look at the graph on the right, the x-axis shows the E to E ratio, and the y-axis shows the wedge pressure. And those with a BMI greater than 35 are depicted by the line in red, and those who are not obese are depicted by the line in black. And as you can see, for any given E to E prime ratio, the filling pressures are actually much higher in HFpEF patients than they are for those without HFpEF, which kind of highlights one of the big limitations of interpreting echo here. There are also limitations to interpreting natriuretic peptide levels. So obesity is associated with NP deficiency, with 20 to 35% of HFpEF patients actually having normal NP levels. And the mechanism of this is unclear, and it may be related to either decreased production, abnormal processing, or increased clearance. But regardless, this is another barrier to diagnosing HFpEF, and particularly in those with obesity. So this brings us to one of the paradoxes of obesity and heart failure risk. We know that obesity portends a higher heart failure risk. We know that elevated NPs portend a higher heart failure risk. But strangely, obesity is associated with lower natriuretic peptide levels. So one of the questions our lab had to address this is to ask the question, do natriuretic peptides predict heart failure risk consistently across the BMI range? So we have two of the members of our lab, Mandana and Juhi, who Mandana is currently a Yale cardiology fellow, and Juhi is one of our biostatisticians. And they conducted a study looking at this question. And this graph is a good depiction of the results of that study. X-axis is BMI, and the y-axis here is the hazard ratio that is associated with the association between natriuretic peptides and the risk of future heart failure. And what we found was that BMI actually modifies the effect of NPs on future heart failure risk, whereby a lower effect size is seen at a higher BMI. So specifically, if you have a BMI of 20, the hazard ratio associated with heart failure risk with a given NP level is 2.21, but this drops to 1.75 when you have a BMI of 40. So this raises the question of whether we actually may need lower NP cut points to actually classify heart failure risk appropriately in the setting of obesity. So given that we have limitations on resting echo and biomarkers, we have to ask the question of whether there's anything we can do to provoke the pathophysiology of HFpEF. And one of these measures of provoking HFpEF is exercise. Exercise intolerance is the hallmark symptom of HFpEF, and it can actually unmask abnormal cardiovascular reserve even in the absence of overt volume overload. And this is shown nicely in the graph to the right. Again, x-axis here is showing the stages of exercise, and the y-axis is showing filling pressures, so the wedge pressure here. So at rest, those with HFpEF in the lighter gray above, and those without HFpEF below, have pretty similar filling pressures. But as you progress through the stages of exercise, you start to see the separation, whereby HFpEF patients begin to have elevated filling pressures. So exercise is an incredibly useful tool to bring out these abnormalities, and that's why tools such as invasive CPET examination can be very useful to diagnose HFpEF, even when, at rest, the filling pressures are not abnormal. So this motivated the MET-CPET study, which we conducted in order to answer that first question I posed, which is the burden of HFpEF and obesity. So we took a set of volunteers between ages of 30 to 80 with dyspnea, obesity, and no cardiovascular disease. All 78 of these individuals underwent echo, and those who had evidence of pulmonary hypertension on echo then qualified for an invasive CPET, of whom 40 met criteria. We then looked at patients who actually developed HFpEF or were diagnosed with HFpEF on invasive CPET. And for that, we used the hemodynamic criteria for HFpEF, either resting filling pressure elevation more than 15, or a change in the wedge pressure over cardiac output slope ratio of more than 2. And then we compared the clinical echo and CPET characteristics between those with and without HFpEF. And the first major takeaway is that HFpEF may be substantially underdiagnosed in those with obesity. Remember, these are all individuals who have no known cardiovascular disease and just volunteered for our study. And the left-sided pie chart shows the total of the 78 who first came to get their echocardiogram. And the pie chart on the right shows just the 40 who actually qualified for CPET and were able to have a HFpEF diagnosis ascertained. And we found that up to a third of volunteers with obesity and dyspnea in the overall population had undiagnosed HFpEF, and this proportion increased substantially to 60% among those who qualified for CPET. We then wanted to ask the question whether we could have distinguished these patients prior to invasive CPET. So we went back to those heart failure scores that I mentioned earlier, HFpEF on the left and H2FpEF on the right, and looked at the distribution of scores between those without HFpEF on top and with HFpEF on bottom. And as you can see here, most patients were actually categorized as low or intermediate risk for HFpEF clinical prediction scores, regardless of whether we actually found them to have HFpEF or not, indicating that these non-invasive scores were not sufficient to distinguish between these patients. So to summarize this first question, we found that HFpEF is likely substantially underdiagnosed amongst those with obesity, and we estimated that it affected up to a third of our volunteers with obesity and dyspnea and no known cardiovascular disease. And traditional resting non-invasive methods like echo are likely inadequate to identify HFpEF in the community. So transition to the next section of our talk and question number 2. While invasive CPET is the gold standard for the diagnosis of hemodynamic evidence of HFpEF, we wanted to know whether there are still opportunities to explore other provocative maneuvers to better capture HFpEF on echo. And I'll leave Jen to talk about that.
Thank you, Leah. I'm going to start screen sharing. Let me just switch to that. All right, awesome. So welcome again, everyone. Really excited to talk here today together with Leah. I think what I wanted to do with the rest of the talk is really give you a glimpse of some of the smaller patient-oriented physiology-based studies that we're really interested in, rather than focusing on large clinical trials, because I think there's a lot we can learn about obesity HFpEF using these patient-oriented translational approaches. So as Leah mentioned, obesity HFpEF is really hard to diagnose, and we're missing potentially a large proportion of people who have this. And exercise typically is thought to be one way by which we can unmask abnormal cardiopulmonary physiology. Our lab's been really interested, because exercise isn't always feasible or scalable, to study other provocative maneuvers. And this is work led by folks shown at the bottom here. And so we know from other studies that passive leg raise represents a preload stress. Our collaborator, Mike Nelson at UTA, has also shown that isometric hand grip represents an afterload stress. It actually increases heart rate and blood pressure, similar to putting someone on a cycle ergometer and actually exercising them. And so we currently have a pilot study really looking at using these provocative maneuvers and together with echo imaging to see whether we can get a better sense of diastolic reserve and really to identify people with early HFpEF who have obesity. And so this is our protocol modeled very nicely by Sophie, one of our clinical research coordinators. So we first assess maximal hand grip. We then perform a resting echo, including assessment of diastolic function. We then perform diastolic function measurements after passive leg raise, so preload stress, and again, in the context of isometric hand grip or afterload stress. So what have we found? This is a small study so far. Our first 14 patients have taught us this. So on the left-hand side, you can see with passive leg raise, we do increase mitral E over E prime ratio by a little bit, but certainly this is much more exaggerated on the right-hand side after we perform isometric hand grip. And so we do think isometric hand grip is potentially able to really uncover impaired diastolic reserve in these individuals. Interestingly, when we take mitral E over E prime ratio after isometric hand grip, so with this provocative maneuver, and we look to see whether it's correlated with exercise capacity as measured by peak VO2, we see this pretty strong negative correlation. So this is telling us on the right that the higher your mitral E over E prime ratio after provocation, so the more impaired your diastolic reserve is, if you will, the worse your exercise capacity as measured by peak VO2. And so we're really excited to potentially use these provocative maneuvers as a potential assessment tool to pick up obesity HFpEF perhaps earlier in the disease stages. Now, I'm going to turn to the second question that Leah posed, which is how do we get from obesity to HFpEF? What drives disease pathogenesis? And of course, many groups around the country and the world have worked on this. I like this study, which just highlights that this is multifactorial and complex. This was led by Mariana Ramirez in our lab. We know that adipose tissue is not passive, but actually active. It secretes lots of adipokines. One of them is leptin. So you can see here higher leptin levels were associated with HFpEF. We also think that systemic inflammation plays a central role, as really captured by CRP in this particular forest plot. And in fact, the majority of patients with obesity HFpEF have evidence of heightened inflammation, with 1 in 5 actually having these really high levels of CRP greater than 10. And so I do think that in general, we think systemic inflammation has to be involved in how we get from obesity to HFpEF, and yet the exact disease mechanisms or molecular pathways still remain unclear. We've really been interested in a class of molecules called eicosanoids. These are bioactive lipids derived from arachidonic acid and other polyunsaturated fatty acids. And the reason is twofold. Number one, we think that some of these eicosanoids really govern upstream initiation of both pro and anti-inflammatory activity. And number two, they're actually therapeutically targetable, if you will. So I'll just show you a glimpse of one of the studies. This was a study where we took 500 individuals who had undergone CPET and had gold standard hemodynamic assessment or classification of HFpEF. And we found 70 eicosanoid metabolites that were associated with HFpEF status. On the right is a volcano plot, and you can see that a number of these metabolites actually were associated with lower odds of HFpEF or protective toward the left of the unity line. There were a number of metabolites that were also associated with higher risk. I'll point out one metabolite specifically that I think is just super interesting because it keeps popping up. This is following on the heels of last week's grand rounds done by Drs. Gersten and Robbins. 12-13-dihome is an exercise lipokine that sort of keeps coming up. It actually is released by brown adipose tissue, so the good type of fat, if you will, and improves how skeletal muscle metabolizes fatty acids. We went on to validate these results. 18 of the 70 eicosanoid metabolites are associated with incident or future development of heart failure in the multi-ethnic study of atherosclerosis. And Leah is currently actually leading other work to expand into further cohorts to really look at incident HFpEF or future development of HFpEF. Now, an interesting question we were able to ask in this study was whether or not eicosanoids are potentially the molecular mediators that make us go from obesity to HFpEF. And so in this mediation analysis, you can see that we do indeed find that higher BMI is associated with higher risk of HFpEF. And here, 8,9-EPETE, which is one of the metabolites, actually the highest hit that was associated with lower odds of HFpEF, mediates about 21% of the effect. And when we looked in the literature, this is sort of super interesting. 8,9-EPETE is an epoxide. It's actually an EPA derivative. And inhibits macrophage activation. So potentially one plausible mechanism by which inflammation leads to HFpEF. There's, of course, lots of ongoing work that's required to take this to the next level. As mentioned, we're doing external validation studies and trying to use Mendelian randomization approaches and other ways by which we can really be more certain about causality. Switching gears from systemic inflammation, I think this diagram put forth by Walter Paulus over 10 years ago actually really encapsulates how we think about disease pathophysiology. So on the right, they really thought of HFrEF as a myocyte-specific primary problem. And on the left, in contrast, HFpEF is really driven by comorbidities, in our case, obesity, that then leads to systemic inflammation that then has effects on endothelial function and secondary cardiac remodeling. And so we've been really interested in trying to better understand the role of endothelial dysfunction in HFpEF pathogenesis. And what I'm really excited about is that we've developed this new technique to actually isolate human venous endothelial cells from patients with HFpEF. This is in collaboration with Naomi Hamburg at BU. And what we can do is we can perform targeted molecular phenotyping to look at very specific proteins or even markers of endothelial cell activation or function. We can also do gene expression profiling or overall transcriptomics to look at gene signatures that might be up or down regulated in the context of human disease. And so I'll just give you one glimpse of a small study that's yet unpublished, led by Leah and Emily Lau in the lab. We did a case control study of 71 patients with HFpEF and age and sex-matched controls. We isolated venous endothelial cells and performed transcriptomic profiling. And on the right is the volcano plot that's really looking at differential gene expression in people with HFpEF and their matched controls. You can see there are 19 differentially expressed genes. And what I thought was super interesting is when we look through this gene list, a lot of them are obesity related. So for example, apelin is a adipokine that's really been known to affect and regulate vascular and cardiac and immune function. And TUB is a gene, actually it stands for tubby, and it's a gene that's known to be associated with obesity-related traits. So a lot of really interesting sort of known biology that's recapitulated in our endothelial cells from HFpEF patients. We did a pathway analysis, and what pops up as well is extracellular matrix interactions. Again, all things that we think might lead to increased arterial stiffness, fibrosis, and ultimately HFpEF. So I think we're really excited to use this as a platform to better understand how obesity might affect microvascular dysfunction that then leads to HFpEF. So in sum, how does obesity drive HFpEF pathogenesis? We certainly think systemic inflammation is key. We are trying to dive deep into potential molecular pathways to do with these bioactive lipids called eicosanoids. I'll point you to other people's work. There are ongoing trials that are really trying to target inflammation in HFpEF. The largest one currently is Hermes, which is using an anti-IL-6 inhibitor. And this is a large multi-center trial led by Paul Ridker that's currently recruiting. And then we and many others are really interested potentially in better understanding contributions for microvascular dysfunction as well as potential therapeutic targets. So in the last few minutes, I'll turn to this last question that Leah posed, which is whether obesity is the whole story. And I'll just flag this publication that was recently released, really led by Milton Packer, which is the adipokine hypothesis. This was also presented at ESC a few weeks ago. And in this, Milton Packer really argues that HFpEF is all due to dysfunctional adipose tissue that then releases adipokines, which then make you have HFpEF. And so our question was, well, is this really very broadly applicable, or do we have to take a more nuanced approach? And I would argue the latter is really true. We know that not everyone with obesity is at the same HFpEF risk. So to take a step back clinically, we know that the prevalence of HFpEF is much higher among women. In fact, women outnumber men 2-to-1 for hospitalizations, 3-to-1 for new heart failure presentation. And I think some of this sex difference is actually driven by how women with obesity are different from men with obesity. So here are data from 4 large community-based cohorts with cumulative incidence of future HFpEF shown on the y-axis. And you can see that women with obesity in the solid red lines are at much higher risk and greater susceptibility than even men with obesity shown in the solid blue. We don't know why this is. I think this is a super interesting topic that we've been thinking a lot about. We can get some glimpses as to why women are predisposed to HFpEF compared with men from this study led by Emily Lau. So we looked at 71 cardiovascular biomarkers in ostensibly healthy individuals. And you can see that there's just tremendous sexual dimorphism in cardiovascular biomarkers. And what was super interesting is that biomarkers that represent pathways of inflammation and adiposity are upregulated among women. And by contrast, pathways of fibrosis and platelet activation are upregulated in men. So this may be one way by which women are just predisposed to developing HFpEF in the context of obesity. The other question that's been really interesting is that we know obesity is maybe too rough of a tool in that we think specific adipose depots may play a specific role. So in particular, visceral adipose tissue is thought to be sort of the most metabolically active and have the most adverse consequences. And interestingly, when you look at epidemiologic studies, men have greater visceral adipose tissue compared with women, and women tend to have more subcutaneous fat. But does that actually mean they're at differential cardiovascular risk? So that was a question that we asked in this particular study. So here in this forest plot on the right, I show associations of visceral adipose tissue with various cardiovascular biomarkers that encapsulate cardiovascular risk. And the effect estimates for women are shown in red and for men are shown in blue. And the first observation is that there are many biomarkers that are associated with visceral adipose tissue, and that for nearly all of them that represent adiposity, inflammation, and fibrosis, for a given amount of visceral adipose tissue, women have worse biomarker profiles compared with men. So the red effect estimates are farther away from 0 compared with the blue effect estimates. I think this is so fascinating. So just as an example, that first biomarker shown here, IGF-BP1, again, you can see women have lower levels compared with men that are associated with visceral adipose tissue. And it turns out IGF-BP1 helps you regulate glucose, lipid, and vascular metabolism, and lower levels are associated with worse cardiovascular risk. Similarly, leptin, which is that very last one, is a sort of classic adipokine. Here you can see women have higher levels associated with visceral adipose tissue compared with men. We know that leptin amplifies systemic inflammation and all of the other things that would set you up for HFpEF, including arterial stiffness, myocyte hypertrophy, fibrosis, et cetera. So I think this stands to reason that there is sexual dimorphism in adipose traits and how they relate to cardiovascular risk. So in conclusion, we do think obesity is a key contributor to HFpEF. Adipose tissue isn't just passive, it's an active endocrine and paracrine organ, and it can communicate with multiple organs, including heart, vasculature, and immune system, all things that we think are germane to HFpEF disease pathogenesis. There are many other factors at play, however, apart from just obesity. I didn't have time to show these data today, but we know that weight loss alone doesn't solve HFpEF, and that a lot of our evolving therapies, including incretin-based therapies, not only cause weight loss, but they also reduce inflammation, and they do lots of other things besides weight loss that benefit our HFpEF patients. There is tremendous phenotypic heterogeneity, and so I've highlighted mostly sexual dimorphism, but we do know that there are many other forms of HFpEF in the context of multimorbidity with hypertension, diabetes, atrial fibrillation, et cetera. And I think in the future, certainly using these multi-omic and patient-oriented studies looking at multiple tissue types may help us really resolve specific disease mechanisms. So in the last minute or so, let's turn back to our patient case. So recall she's 57, dyspnea on exertion, intermittent leg swelling, BMI of 35, and really normal workup so far, including normal PFTs, resting echo, and a low NT-proBNP. So the first question is, does she have HFpEF? The answer is really maybe, right? The teaching point or the thing to recognize is that a normal resting echo and normal natriuretic peptide levels don't rule out HFpEF. And we think HFpEF is likely underdiagnosed among individuals, in particular with obesity. What diagnostic testing would we pursue? We can consider so certainly mainstay of diagnosis is echo natriuretic peptide levels, your clinical assessment and exam. If the diagnosis is still unclear, I think provocative testing is particularly important, including CPET. And we have ongoing studies to see whether some of these provocative maneuvers might help us kind of identify people early on who are at risk. And then lastly, what treatments would we consider? This is a whole separate talk, but we do know that there is now GDMT for HFpEF. The mainstay is really centered around SGLT2 inhibitors. There are evolving data around non-steroidal MRAs. And then certainly in the context of HFpEF and Summit, I think incretin-based therapies should be something to strongly consider. There are many, many other trials in this space. We touched on Hermes as a way to target inflammation. There's rehab HFpEF to really look at cardiac rehab and many others. And I'll say that, over 10 years ago, when I first became interested in HFpEF, we really had nothing. And this has just been this accelerated, extraordinary explosion of potential therapies and ways to treat HFpEF in the last few years that has been really exciting to be a part of. So I'll stop here. I'll acknowledge all of our lab members and the entire division here for all of their support. This has been really, really fun work to do. And I'll turn it back over to Leah, who I think had a couple of other thoughts particularly as we consider that all of the applicants are joining us this morning.
Yes. So I wanted to give you a brief pitch as to why you should come to BI, given that, you're all on the line listening to this today. So I have a few credentials for this. First, I was a fellow here for 4 years. I was a chief fellow 2 years ago. And I also got the chance to do my T32 fellowship, as well as a master's degree at the Harvard School of Public Health over the past 2 years. And my first reason for why you should come to BI is the mentorship team. Of course, there's Joe and Coco and Rishi, who are the actual fellowship program leadership, but you also get an incredible amount of mentorship from Rob Gersten, of course, our division director, as well as Jen, and so many other people. You meet with all of them regularly, and they really help make sure that you are going along the career path that is best for you. The second reason is the flexibility. So BI is a very front-loaded program, which gives a huge advantage whereby the third year is totally customizable. I decided to do research and get my master's degree, but my co-fellows got an early start in EP or cath. They did imaging. Some of them even pursued specific clinical interests like vascular medicine, cardio-onc, etc. The world is your oyster. And then the most important third reason of why to come to BI is, of course, your future co-fellows. This is my class when we went to go visit Rob's place in Martha's Vineyard right in the beginning of our first year. So if the idea of being on a beach and matching Hawaiian shirts with your co-fellows appeals to you, you should definitely consider coming to BI. And that's my pitch for you.
Thank you so much, Jen and Leah. Amazing talk. Unfortunately, just given the time, we don't have time to take questions, but please feel free to email. This is an amazing talk, amazing work, much done and much to be done. So appreciate you all. And for the fellows, have a wonderful, wonderful day. Bye.